Welcome to Pediatric Case Review. Today we will explore tuberculosis in children through a comprehensive case-based approach. We will cover clinical presentation, diagnostic methods, treatment protocols, and important complications. This lecture contains multiple choice questions followed by detailed explanations. Let us begin our learning journey. Question 1. A 4-year-old boy presents with persistent cough for 5 weeks, low-grade fever, and poor appetite. His mother recently started treatment for pulmonary tuberculosis. What is the most likely diagnosis? Option A, bacterial pneumonia. Option B, pulmonary tuberculosis. Option C, viral bronchitis. Option D, asthma. The correct answer is option B, pulmonary tuberculosis. This child has classic features of pediatric tuberculosis, including persistent cough lasting more than 3 weeks, constitutional symptoms like fever and poor appetite, and most importantly, a clear epidemiological link with a household contact who has active tuberculosis. Children are particularly vulnerable when exposed to infectious household members. The duration of symptoms exceeding 3 weeks and the presence of constitutional symptoms strongly suggest tuberculosis rather than common viral or bacterial infections. Question 2. An 18-month-old infant presents with failure to thrive, intermittent fever, and decreased playfulness for 3 months. No obvious respiratory symptoms. Chest X-ray shows miliary pattern. What type of tuberculosis is this? Option A, primary pulmonary tuberculosis. Option B, latent tuberculosis infection. Option C, miliary tuberculosis. Option D, tuberculous lymphadenitis. The correct answer is option C, miliary tuberculosis. Infants under 2 years of age are at highest risk for disseminated tuberculosis due to immature immune systems. Miliary tuberculosis presents with nonspecific symptoms such as failure to thrive, prolonged fever, and lethargy rather than typical respiratory symptoms. The miliary pattern on chest X-ray, characterized by numerous small nodules throughout both lungs, confirms hematogenous dissemination of Mycobacterium tuberculosis. This represents one of the most severe forms of tuberculosis requiring urgent treatment. Question 3. A 7-year-old girl being evaluated for tuberculosis contact has painless, firm, non-tender cervical lymph nodes measuring 3 centimeters. No other symptoms. What is the most appropriate next step? Option A, antibiotic trial. Option B, tuberculin skin test and chest X-ray. Option C, immediate lymph node biopsy. Option D, observation only. The correct answer is option B, tuberculin skin test and chest X-ray. Painless, firm lymphadenopathy, particularly in the cervical region, is a common manifestation of tuberculosis in children. The presence of tuberculosis contact history makes this highly suspicious. The appropriate evaluation includes tuberculin skin test or interferon gamma release assay to detect infection, plus chest X-ray to assess for pulmonary involvement. Lymph node biopsy may be needed if initial tests are inconclusive, but starting with non-invasive testing is standard practice. Empiric antibiotics would not be appropriate without proper diagnosis. Question 4. A 5-year-old develops tuberculosis 6 months after exposure to his grandfather with active pulmonary tuberculosis. What is the primary mode of transmission? Option A, fecal-oral route. Option B, airborne droplet nuclei. Option C, direct skin contact. Option D, blood transfusion. The correct answer is option B, airborne droplet nuclei. Mycobacterium tuberculosis is transmitted through inhalation of airborne droplet nuclei that are expelled when an infectious person coughs, sneezes, or speaks. These tiny particles can remain suspended in air for extended periods and reach the alveoli when inhaled. Children typically acquire tuberculosis from prolonged close contact with infectious household members, explaining why family contacts represent the highest risk group. The 6-month incubation period before symptoms develop is typical for primary tuberculosis infection in children. Question 5. A 3-year-old child with BCG vaccination at birth needs tuberculosis screening after daycare exposure. Which test is preferred? Option A, tuberculin skin test. Option B, interferon gamma release assay. Option C, chest X-ray only. Option D, clinical observation. The correct answer is option A, tuberculin skin test. For children younger than 5 years of age, tuberculin skin test remains the preferred screening method even in BCG vaccinated children. While interferon gamma release assays are not affected by BCG vaccination and can be used in children 2 years and older, guidelines recommend tuberculin skin test as the primary screening tool in young children due to better validation in this age group. The test should be read at 48 to 72 hours, with induration of 5 millimeters or more considered positive in high-risk contacts. Question 6. Chest X-ray of a 6-year-old with tuberculosis contact shows right hilar lymphadenopathy and a small peripheral infiltrate. What is this pattern called? Option A, miliary pattern. Option B, primary complex. Option C, cavitary disease. Option D, pleural effusion. The correct answer is option B, primary complex. The primary complex, also called the Gone complex, consists of the initial lung parenchymal lesion called the Gone focus plus enlarged regional lymph nodes, typically hilar or mediastinal. This is the characteristic radiographic finding in primary tuberculosis in children, representing the initial site of infection and the regional lymph node response. Unlike adults who commonly develop cavitary disease, children typically present with this lymph node predominant pattern. The primary complex may calcify over time, leaving a permanent radiographic marker of previous infection. Question 7. A 7-year-old asymptomatic child has positive tuberculin skin test after tuberculosis exposure. Chest X-ray is normal. What is the recommended treatment? Option A, no treatment needed. Option B, 4-drug therapy for 6 months. Option C, isoniazid for 9 months or rifapentine isoniazid for 3 months. Option D, observation with repeat testing. The correct answer is option C, isoniazid for 9 months or rifapentine isoniazid for 3 months. This child has latent tuberculosis infection, meaning infection without active disease. Treatment of latent tuberculosis is crucial to prevent progression to active disease, which occurs in approximately 10% of infected children. The preferred regimens include 3 months of once-weekly rifapentine plus isoniazid for children older than 2 years, or daily isoniazid for 6 to 9 months. The shorter 3-month regimen has better completion rates and similar efficacy, making it the preferred choice when available. Question 8. A 5-year-old is diagnosed with drug-susceptible pulmonary tuberculosis. What is the standard treatment regimen? Option A, isoniazid alone for 6 months. Option B, rifampin isoniazid pyrazinamide ethambutol for 2 months, then rifampin isoniazid for 4 months. Option C, 3-month short course. Option D, observation only. The correct answer is option B, rifampin isoniazid pyrazinamide ethambutol for 2 months, then rifampin isoniazid for 4 months. This standard 6-month regimen for drug-susceptible tuberculosis consists of an intensive phase using 4 drugs for the first 2 months to rapidly reduce bacterial load, followed by a continuation phase with 2 drugs for 4 additional months to eliminate remaining dormant bacteria. This regimen achieves cure rates exceeding 95% when completed as prescribed. Recent guidelines also support a 4-month regimen for non-severe disease in some children, but the 6-month regimen remains standard practice globally. Question 9. A 2-year-old with diagnosed miliary tuberculosis develops decreased consciousness, neck stiffness, and bulging fontanelle. What complication has occurred? Option A, pneumonia. Option B, tuberculous meningitis. Option C, hydrocephalus alone. Option D, seizure disorder. The correct answer is option B, tuberculous meningitis. Tuberculous meningitis occurs in 20 to 40% of children with miliary tuberculosis and represents the most devastating complication of tuberculosis. The clinical features include altered consciousness, meningeal signs like neck stiffness, cranial nerve palsies, and in infants, bulging fontanelle indicating increased intracranial pressure. Children under 2 years face highest risk. Tuberculous meningitis requires immediate treatment with 4-drug therapy plus corticosteroids to reduce inflammation and prevent permanent neurological damage. Even with treatment, mortality and morbidity remain unacceptably high, emphasizing the importance of early diagnosis and prevention. Question 10. An 8-year-old with tuberculous meningitis has completed 1 month of treatment but develops progressive headache and vomiting. CT scan shows ventricular enlargement. What is the likely complication? Option A, drug toxicity. Option B, treatment failure. Option C, hydrocephalus. Option D, brain tumor. The correct answer is option C, hydrocephalus. Hydrocephalus is a common and serious complication of tuberculous meningitis, occurring in approximately 40 to 80% of cases. It results from obstruction of cerebrospinal fluid flow due to thick basal exudate or blockage of arachnoid granulations. Clinical features include worsening headache, vomiting, altered consciousness, and papilledema. Management may require temporary external ventricular drainage or permanent ventriculoperitoneal shunt placement in addition to continuing anti-tuberculosis therapy. Early recognition and neurosurgical consultation are essential to prevent permanent neurological sequelae. Question 11. A newborn's mother is diagnosed with smear-positive pulmonary tuberculosis 2 days after delivery. What is the appropriate management for the infant? Option A, separate mother and baby immediately, no prophylaxis. Option B, isoniazid prophylaxis and delayed BCG. Option C, immediate BCG vaccination. Option D, no intervention needed. The correct answer is option B, isoniazid prophylaxis and delayed BCG. Newborns exposed to infectious tuberculosis represent extremely high-risk contacts requiring immediate intervention. The infant should receive isoniazid prophylaxis for at least 3 months, during which time the mother should be separated until she is no longer infectious, typically after 2 weeks of appropriate treatment. After 3 months, tuberculin skin test should be performed. If negative, BCG vaccination can be given and isoniazid stopped. If positive, continue treatment for latent tuberculosis infection. This approach prevents progression to severe disseminated disease while allowing safe mother-infant bonding once the mother is non-infectious. Question 12. A 10-year-old immigrant child received BCG vaccination at birth. Tuberculin skin test shows 15 millimeters in duration. How should this be interpreted? Option A, false positive due to BCG. Option B, true positive infection. Option C, normal response to BCG. Option D, requires repeat testing. The correct answer is option B, true positive infection. While BCG vaccination can cause positive tuberculin skin test reactions, several factors indicate true infection in this case. First, BCG was given at birth, and its effect on tuberculin skin test typically wanes after 5 years. Second, reactions larger than 10 millimeters, especially 15 millimeters, are more likely to represent true Mycobacterium tuberculosis infection rather than BCG effect. Third, the child is 10 years old, making BCG interference unlikely. This child requires full evaluation for tuberculosis, including chest X-ray, and should be treated for latent or active tuberculosis as indicated by findings. Thank you for watching. Join our pediatric case review community on Patreon, where you will find all our educational videos systematically organized by topic, making it easy to access exactly what you need. All presentations are available as high-quality images, so you can read and practice questions at your own pace. For complete details and information about how to subscribe, please comment below this post, and we will personally message you with all the information you need. We have completed our comprehensive review of tuberculosis in children, covering clinical presentation, diagnostic approaches, treatment protocols, and important complications. I hope this case-based format helped reinforce your understanding of pediatric tuberculosis. Please subscribe to Pediatric Case Review for more informative medical presentations. If you have any questions or topics you would like us to cover, please leave a comment below. Thank you for learning with us today.